Good afternoon to everyone. I welcome everybody again to this platform where we'll be discussing about healthcare associated infections and its prevention. Well, to start with, I'm Dr. Upasana Bhumbla. I'm Associate Professor in Department of Microbiology, Adesh Institute of Medical Sciences and Research, Bathinda. I'm also the Member Secretary and the Infection Control Officer out here. So as I just briefed earlier 5 minutes back, that the first part of the conversation will be all about what is healthcare associated infections, what it composes of, what are the functions, what are the surveillance patterns, and what are the various parameters what we require for the surveillance. To start with, I think everybody out here might be aware of the word hospital associated infections, healthcare associated infections, nosocomial infections. So these were all the parts what we used to name it earlier, either healthcare associated or nosocomial or healthcare associated. Nowadays, the word is being used as healthcare associated infections. So HAIs are nothing but any infection which in a hospitalized patient, which was not present at the time he or she was admitted to the hospital, but was incubated during this period of hospitalization, he or she has acquired it. Our main motive for this complete lecture is all about to briefly address what exactly healthcare associated infections is all about. So when a person is coming with X disease and during the hospital setup, during the hospital treatment, he or she has acquired during this medical setting, he or she has acquired an Y disease, that is nothing but a healthcare associated infection, or in brief words, if at all we say, it's a hospital acquired infection. So as we know, the history of infection control is far off. It's as old as mankind, and it existed before 19th century also. The pioneers of infection control practices who started with Semmelweis, Louis Pasteur, Joseph Lister, who has been said as the father of antisepsis, Robert Koch, Florence Nightingale, they have all contributed. They have all, again, if at all, I can just say that hospital-acquired are the infections that are acquired in hospital by a patient admitted for a reason other than the infection in context. So X disease के साथ आए हैं और Y disease साथ उनको मिल गया है. That is nothing but a healthcare associated or a hospital-acquired infection. We were talking about the history of infection control. So as I said, it is as old as mankind, and Joseph Lister has played a very important part in giving us the theory of antisepsis. So we look forward that as many less infections we should be giving it to our patient. In fact, zero infection should be giving it to a patient, but due to glitches, due to breaches in the practices, we face this healthcare associated infections. Infection control includes all the policies and procedures which are supposed to be there for the minimal occurrence of the infection. To start with, what is infection control program? It operates basically at two levels. I'm just defining, then I will be letting you know about at what levels this infection control program completely runs in a particular hospital, and what are the composites of this infection control program, what is infection control, hospital infection control committee or the HICC committee. So infection acquired in the medical setting in the course of medical treatment. Patient has come with the X disease and has correspondingly got the Y disease also. Brief history about mankind and the infection control practices. I've just said that. Infection control program operates at two levels. One is the executive body, that is the infection control team. And second is the advisory body, which is the main constituent, which is called as the Hospital Infection Control Committee. And it's basically adopting all the legislative, all the terminologies, all the main decisions of this committee are taken up by these people only. Very efficiently, if I can say what infection control program comprises of, a hospital control program or an infection control program comprises of three aspects. First and foremost is the Hospital Infection Control Committee or the HICC committee, which I am so sure many of you might be having in your hospital setups. Then the second point is the infection control team. This is the team or the core team which does the day-to-day activities and provides us information and lets us know where all the breaches and the breach in the infection control practices are being taken up in the hospital, so that the preventionary measures can be taken up. Thirdly, which is a very important part but mainly neglected, is the infection control manual. This manual comprises of all the data, all the policies and procedures, all the standard operating procedures. It is to be documented in a manual, which is named as Infection Control Manual. So what comprises of the Infection Control Committee? Hospital Infection Control Committee has, first, one second. This committee includes, first and the foremost is the hospital administrator, who is the chairperson. It can be the hospital director or the medical superintendent or the principal of the medical college, if it is belonging to one. So one hospital administrator has to be there because he or she will be responsible for all the major, even the financial issues which can be discussed and can be taken up into consideration. So we need a hospital administrator as a chairperson of Hospital Infection Control Committee. Then up next, the second most member is the member secretary of the Hospital Infection Control Committee. That has to be mandatorily somebody at a higher position in Department of Microbiology who can act as the member secretary for the HICC. Third important point is the clinical microbiologist. As I'm saying, somebody from ID industry or mandatorily it is there for the member secretary, it has to be a microbiologist. But clinical microbiologist or somebody from ID can also become the infection control officer. Fourth important person is the infection control nurse, because infection control officer along with the infection control nurse only will be dealing in the infection control team, and they will be updating us about the day-to-day activities, what is happening in the hospital. Then we have the general physicians, general surgeons, people from the broader specialty, super specialty areas who can give their inputs, who can give the areas where maximum number of microorganisms or any breach in the major practices is going on. So they can be a very leading people in the hospital infection control committee. Then we have the director of nursing, or we call it as the nursing superintendent. They have the prime role because they will be helping us out to have a hold of all the nursing staff, filling up all the documentations, following the procedures, wherever the invasive procedures are being done, whether they are following it or not. So nursing superintendent can have an eye on all the nursing department and give their inputs in this HICC meeting. Then we have the person from occupational health physician, that is maybe the ID specialist. Not all hospitals have the ID specialist, but if available, yes, they can be kept in this group. Then representatives from the major clinical specialties, I just said that people from orthopedics, people from surgery, people from pediatrics has to be there. So all the collective data of the hospital can be collected by the respective representatives. Then lastly, we have the additional representatives from other departments like operations, where all the practices are being taken by the lower staff, by the ground staff. Is it done properly or not? Operations guy can help you out. Person from pharmacy, letting us know what are the over the counter drugs which are available. Is there any restricted policy for major antibiotics, whether the 3-slip method is being taken up by all the high risk patients and the main antibiotics are not given over the counter. Then we have a person from CSSD, Central Sterile Supply Department. He or she might be taking up the response that yes, all the practices, all the materials which are being sterilized well, and they are sent to either the OTs or the wards or the ICU areas with the proper packing, and followed by that, the indicators are being followed or not. Then we have the person from maintenance and the housekeeping. As I said, they are one of the backbone for the hospital. The ground staff actually does all the minor or the major work or the cleaning work. So operations and housekeeping people are very, very important for any hospital to work properly in relation to infection control. As I said, infection control team comprises of only 2 people. One is the infection control officer, that is the microbiologist, and we have an infection control nurse. So every hospital, every 200, more than 200 bedded hospital, it is mandatorily to have an infection control officer. In fact, even the smaller setups are supposed to have an infection control officer. Plus, every 250 beds, we need a 1 infection control nurse. And this infection control team collectively are responsible for day-to-day activities and which functions for the infection control. One point here in Hospital Infection Control Committee, if it's a bigger setup, every quarterly we need to have a Hospital Infection Control Committee meetings. If not, Twice in a year, it is required that people should have it. If you can have it every month, nothing like that, because as per NABH standards, if at all every month you're having a hospital infection control committee meetings, you will be leading your hospital to a new horizons, and you will be able to address problems very easily. Right. Then we talk about the prerequisites which are there for the infection control manual. So infection control manual, first and the foremost, it should define the organogram of the hospital, what I said in HICC, that who all are the members, what are their respective duties, and how well they are performing, and what are the policies and procedures, what are there. Then the risk categorization of hospital areas. What are the hotspots? What are the labeled areas? A blueprint of your hospital placard should be there. Then surveillance mapping. What are the different surveillance parameters you are taking up? Then hand hygiene, what is the compliance and the non-compliance, and how you are checking the compliance and non-compliance of hand hygiene, which will be dealt in the later part of this lecture of ours. Then what are the standard precautions? We all know from head to toe what are the prerequisites we require. Isolation precautions, I think the world knows about it. We have all gone through this pandemic all together. So what are the isolation practices? What particular rooms are required? What are the air exchanges which are required? What are the prerequisites for isolation precautions? They all should be documented well in your infection control manual. Again, high risk areas, the hotspots, and maximum number of microorganisms which can be dealt, especially talking about burns area and your. Then we have the occupational exposure or any body fluids. What are the protocols? What you follow for that? 1 second, I should close this. Okay, then the recommendations of cleaning and disinfection. What are the cleaning practices? What are the disinfectants? Are you using the quaternary ammonium compound, or what are the other prerequisites which you are using in your hospital setup, especially in the intensive care units, in your cath labs, in your OTs, dialysis centers, in your critical and non-critical areas? Then yes, in an infection control manual, we need to have a vaccination policy of your hospital. So basically, we say about only the influenza vaccination, hepatitis B type B vaccination, and TT vaccination for your GDA staff. Nowadays, it is mandatorily to document the 2 doses and plus the booster dose for COVID also. Outbreak management, as I said, the world has faced about COVID. We all have together faced this pandemic. So what were the prerequisites you had in your infection control manual regarding the outbreak? Mortuary, yes, these were the points. Lately, it has been raised in NABH to maintain the 5th standard of NABH. We need to have a mortuary policy also. Okay. What are the functions of HICC? Very quickly, if at all I say, yes, HAI surveillance. We'll start with HAI surveillance, what exactly it is. So the 4 parameters which are important is catheter-associated UTI, central line-associated bloodstream infections, ventilator-associated pneumonias, and surgical site infections. So developing a system for identification, you are identifying, you are reporting, finally analyzing the data, and what is the preventive and the control methods for reducing this healthcare associated infections. Then what are the other functions includes, what are the different antibiotic policy? Do we have an antimicrobial stewardship policy? What is the antibiograph of my particular hospital? What does it states? So making all these properties and making them align in one stream is the utmost importance and the function of HICC. How we are dealing with this outbreak management, I just said that we have all worked together and we've overcome this pandemic. I know, last but not the least, but we are trying to overcome this pandemic. And what are the reviews in the previous meetings? What are the agendas in the previous meeting which were raised, whether it was closed or not? What are the upcomings which is required by the infection control committee? So all these points, all these are the functions for the hospital infection control, healthcare associated, for reducing the healthcare associated infections. So since we were talking about the surveillance system for the healthcare associated infections, to define surveillance, it is nothing but the systematic method of collecting, of consolidating and analyzing the data, which definitely concerns the hospital, and how we are collecting and analyzing, finally leading it to the corrective actions, what is required to reduce the healthcare associated infections. So this quickly, this cycle, this flow chart says implementation of surveillance. Our goals should be defined, what all we are looking for, what are the collection data, what are the protocols for the collection data. We'll be just dealing one by one, and I'll show you how we are picking up the data in my hospital. Then feedback is important. Feedback is important everywhere. How we are analyzing the data, what are the interpretations, and all these interpretations, all these comparisons, are this valid, or if there are queries about that, that can be spoken about. So when you have analyzed, when you have interpreted a data, then what are the decisions you have taken for the prevention of it? And finally, if you have taken the prevention measures, if you have taken the precautionary measures, so how well you have gained it and how well you have reduced the trends of healthcare associated infections. So this is the main importance of surveillance, and how hospital surveillance is very, very important. To start with surveillance, first for the hospital, for the healthcare associated infections to reduce, first parameter I'm dealing with is catheter associated urinary tract infections. So what does this define as catheter associated urinary tract infections? So COTI, a UTI wherein an indwelling urinary catheter was placed for more than 48 hours, taking up days 1 as the time when the device was placed inside in situ. And if an indwelling urinary catheter was in place for more than 2 calendar days and then removed, so the date of the event for the UTI must be the day of discontinuation or the next day of the UTI to be catheter associated. So catheter associated UTI is nothing but beyond 48 hours, patient has been admitted, and the day 1 when the patient was catheterized, after that patient has developed any symptoms, he has got organism in his urinary sample sent after 48 hours. So he or she can be labeled as catheter associated UTI. So there are two terms in this. One is symptomatic urinary tract infections. The other one is asymptomatic urinary tract infections, SUTI and ABUTI. So SUTI, as the word itself defines, symptomatic hai. So it must meet at least one of these criteria, which is more than 48 hours of indwelling catheter, and at least one of the signs and symptoms, which includes there should be fever, suprapubic tenderness, costovertebral angle pain or tenderness, and culture positive with organism. Asymptomatic urinary tract infection. So word again itself is defining is asymptomatic, with or without any indwelling urinary catheters. Patient is not having all these symptoms, and there has to be positive urine culture with a significant urine criteria, that is 10 to the power of 5 colony forming units, with no more than 2 microorganisms is considered as ABUTI. So we have SUTI, we have ABUTI. Which are the most commonest organisms we generally deal with urinary tract infections? It is E. coli, as we all know, and in gram-negative bacteria, and Staphylococcus aureus and Staph epidermidis. Coagulase-negative Staphylococcus is very, very common and one of the commonest factors leading to catheter-associated urinary tract infections. So to briefly attain with catheter-associated urinary tract rate, there are few words called as NHN standards or benchmarks which has to be developed. So NHN standards says something else, and to define with, yesterday also we have a brief discussion in our ID units, and we were having a talk about it, that any hospital can define their own benchmarks, what was there last year to what is there at present. So in India, generally it is said that 1.6 to 2.1 per 1,000 catheter days are considered to be one of the benchmarks for COTI, catheter-associated urinary tract infections. So how do we collect this surveillance data? I define what is catheter-associated urinary tract infections, what are the two types, SUTI and ABUTI. Now, how do we collect it? And first and foremost, who collects it? It's the infection control nurse who has to collect this data, and the catheter-associated urinary tract infection rate is considered as number of urinary catheter-associated cases in a month, and the denominator is number of urinary catheter days in that month multiplied by 1,000. So how do we control these catheter-associated UTIs, or what we deal with? So educating, there are strategies based for that, for reducing the healthcare associated burden. So we have the core strategies and the supplemental strategies. So core strategies definitely define the catheter size, what kind of catheter, first and foremost, what kind of catheter you are taking. It is a latex catheter, or because it is very good for short-term catheterization, or it is a silicone catheter because it's good for long-standing catheterizations. Other materials like Teflon and all can be used, but these are the two prerequisites for long and short-term use of catheterization. So what is the size of catheter? Basically, it comes in the French scale. Catheter size are described in French scales, and whether it is of the gauge of 12 to 16 French scale, or that is for men, and 12 to 14 for women, and less than 10, that is 5 to 10 French scale is for children, which is required. So based on that, what is the catheter size we are using, then educating the nursing staff, educating our staff, or what is the checklist, what are the prerequisites required, how to insert a catheter is very, very mandatorily required. And is there a requirement to catheterize a patient? That indication has to be well justified and defined. One second, sorry. So as I said, insert catheters. So this is one of the insertion checklists for mine. So before the procedure, whether hand hygiene was done or not, was there any indication of catheterizing a patient? These are the prerequisites, what we look for. Name, when is the catheter inserted, who is inserting, because none of the nursing staff will take the onus that who has inserted if at all patient lands up into 40. So what is the ID of the patient, designation, who has done it, name and ID of the observer. Mainly here, it can be infection control nurse who has observed this whole idea. So the prerequisites of the patient before, during the procedure, and after the procedure, what are the prerequisites which is required? Is it this insertion checklist has been filled or not? Valid reason, clinical reasons for urinary catheterization. So for how long you're leaving the catheters in place, and ensuring that it is done by a trained personnel only, not some fresher has just joined and he or she is dealing with an immunocompromised or a high risk patient, and they have been asked to insert catheter to a debilitated patient. So that will be very difficult, and that can eventually lead into breach in the practices. So perform hand hygiene before and after insertion, using of sterile gloves, drapes, sponges, antiseptic solutions. Periurethral cleaning is very important, and single-use packet of lubricant jelly is very, very required. Lastly, which is a very insecure thing, what we all do and what the practices are being followed. So properly securing of the catheter place has to be done. So please ensure cleaning is right, but beyond cleaning, after the procedure, so properly securing of the catheter space is very, very much required. Right? This is one of the infection control practices surveillance, what we follow for urinary catheters, also for central lines, for ventilators. Is the patient having MRSA as organism or VRE? And whether the nursing station was clean or not. What all the practices we are following? We are following the surveillance sheet. Right? So if by any chance, if patient develops this catheter associated urinary tract infection, so how do you fill up this form? So this is one practice which is being followed in my hospital. Again, all the prerequisites of the patient which is required is done. Whether the urinary catheter in place was there for more than 2 days, or it was removed after 2 days, but removed on the date of event or the day before. So who inserted the catheter? What was the date of insertion? What was the date of removal? What were the signs and symptoms which the patient had? Then at the right-hand side, we can see the laboratory or the diagnostic testing. If culture was positive, how much was the colony forming units, how much was the quantitative method, how much and how many organisms were there, whether it was single organism or it was a multi-organism system, right? Moving on, next we have the ventilator-associated pneumonias. Ventilator, there's a beautiful picture where it says how does a normal chest looks like and how does a ventilator-associated pneumonias patient looks like, and their chest looks like. Okay, to define with what are ventilator-associated pneumonias, they are defined as pneumonias that occur beyond 48 hours or there are after following endotracheal intubation, which are characterized by the following things: presence of a new or a progressive pulmonary infiltrates on X-ray, signs and symptoms which are specific, either it can be altered WBC count, fever is there, changes in the sputum characterization, or detection of any causative agent. So ventilator-associated pneumonias are the pneumonias which occurs after 48 hours after following of the endotracheal intubation. What are the basic microbes which are involved? So there are two words first and foremost. One is the early VAP, ventilator-associated pneumonia, and second is the late VAP. Early VAP is nothing but during first 4 days of mechanical ventilation, which is caused by typical community-acquired organisms like methicillin-sensitive Staph aureus, H. influenza, Moraxella. So they lead to early onset ventilator-associated pneumonias. Then we have a word called as late VAP. Late VAP, it develops after more than 5 days after mechanical ventilation, and it is mainly caused by opportunistic microorganisms or by the antimicrobial resistance patterns. So multi-drug resistant GNB such as Pseudomonas aeruginosa, Acinetobacter baumannii, or Enterobacteriaceae, carbapenem resistant Enterobacteriaceae are very common. And in gram positives, we have this methicillin resistant Staph aureus, which are the culprits for having this late ventilator associated pneumonias. Also, one word to identify: VAP from fungal and viral causes has a low to moderate incidence, especially in the immunocompetent host. So at times, Candida can be misled and we generally don't treat it. So we should look forward for the fungal infections also, mainly in the immunocompromised patients. So how do you diagnose this? So we have this clinical pulmonary infection score, that is the CPIS score. And it is based on basically these parameters: temperature, the TLC count, what are the tracheal secretions, what are the radiographic findings, what are the culture results it says, and obviously the oxygenation status. So temperature, whether it is afebrile, or patient is having symptoms or fever is high. So based on that, we give a scoring of 0, 1, and 2. TLC count, whether it's normal, 4,000 to 11,000 per cubic millimeter, 0 if it's more than that. So 1, if you have the band cells are there, so it's 2, scoring will be 2. Then we have the tracheal secretions. Tracheal secretions here, I would like to pinpoint on the, I think I'll put up on the cultures. So tracheal secretions, whether there are no as such bad secretions or mild or non-purulent secretions or purulent secretions. So 1, 2, 0, 1, and 2 is the categorization. Radiographic finding showing the first picture as I showed, without any infiltrates, it's a clear chest, so that's a normal human being. So no infiltrates, whether diffuse or patchy infiltrates are there or localized infiltrates are there, we give the scoring. Then we have the culture results or the endotracheal results. So there are two methods first and the foremost. We need to identify. Many a times we see that generally we go for audits, we come across that for bowel samples, for endotracheal secretions, for the other protected specimen brushes, we don't quantify. There are two methods. One is the semi-quantitative method and the other one is the quantitative culture. We take up mainly the threshold value or the quantitative cultures. So here I want to ponder that for endotracheal, just like CAST criteria is there for urine. So we have the criteria, quantitative culture criteria for the endotracheal aspirate, it is more than 10 to the power of 5 colony forming unit per ml. For bronchoalveolar lavage or the bowel samples, we have 10 to the power of 4 colony forming units, and protected specimen brushes, more than 10 to the power of 3 colony forming units is considered as the confounding factors. And lastly, we have the oxygenation status, whether the presence of ARDS or patient with ARDS, right? So clinical pulmonary score, infection score, CPIS score, it ranges from 0 to 12 as we just saw scoring, and more than 6 if at all it is there. It has a strong accessibility that the patient is in ventilator associated pneumonias. So how do you go for the surveillance of that? So VAP rate is defined as the number of ventilator-associated pneumonia cases per month. Denominator is the number of ventilator days per month multiplied by 1,000. So that's how you calculate the surveillance for VAP. So this is the VAE tracking sheet, which is followed in my hospital. So it does the same thing: minimum peak value, FiO2 value, what is the TLC count, what is the temperature lining of the patient, what all antibiotics the patient is getting, what is the organism we have isolated. Sometimes, as I said, the late onset VAB generally defines antimicrobial resistance pattern. So you're taking 1x antibiotic and the patient develop probably resistance after, because they are prolonged patients and they can stay for more than a week. So whether the antibiotic has fallen off resistant, or is there any other parameter we need to assess, or whether there is increase in the microorganisms beyond one bacteria, we have another fungus also associated. So this VAE tracking sheet will help you out to note what was the status of the patient at the first day, what's the status at the 5th or the 7th day. It's the same sheet what I shared you in catheter associated UTIs. So we have it for central lines, for ventilators, we follow the same sheet. So what is a treatment lining? So basically for late onset and we have this cephalosporins, second or the third generation cephalosporins. Ideally, we take up the second generation cephalosporins, and because of the multi-drug resistant organisms prevalent in our industry, there is much of resistance for cephalosporins, for fluoroquinolones, aminopenicillins, for beta-lactam inhibitors. Then we have the second modalities as carbapenemases that can be given with a combinative therapy with colistin. And we have sometimes when the organism is pseudomonas, we can have this anti-pseudomonal fluoroquinolones or the anti-pseudomonal cephalosporins like ceftazidime can be taken up. Plus for the coverage of MRSA, we can have vancomycin and linezolid, which is quite effective for the late onset VAP patients. So what are the practices for VAP patients? Very quickly, first and foremost, I'll just tell you the role of biomarkers in VAP. So we need to rule out procalcitonin, C-reactive protein. One word is like STREM, that is soluble triggering receptor expressed on myeloid cells, or alpha amylase. These are the prerequisite biomarkers we look forward for in this VAP identification. So treatment of VAP, we definitely need to design it and remember it, the 5-element VAP bundle. Patient is intubated. The first and the utmost responsibility of any nursing staff has to be a oral care with proper cleaning of the area of the oral cavity with chlorhexidine. It is at the utmost importance and should be done on daily basis and routinely twice or thrice in a day. It will be very helpful. Then we have this stress ulcer prophylaxis. People are very much prone to have stress ulcers. So for that, PPIs can be given. The prophylaxis for generally for stress ulcers is H2 receptor antagonist. And then the third point is daily sedation assessment and spontaneous breathing trials. Physiotherapy plays a very, very important role out here. So daily sedation, yes, patient can be sedated because he's already ventilated. So you have to break this pattern of sedation. So over sedation predisposes the patient to gastric regurgitation and aspiration, thus leading to stress ulcer. So uske prophylaxis to humne kar liya. But at the same point of time, we need to reduce the sedation practices and continuous physiotherapy, blabbing at the back, and so that the patient is able to breathe out well. The spontaneous breathing trials should be done with the help of physiotherapy people. Then we have DVT, deep vein thrombosis prophylaxis. Debilitated patient is bedridden, so look for these patterns also. And head end of bed elevation is required. As I said, physiotherapy, this practice should also be done 3 to 4 times in a day to have a proper care for the VAP patient. This is just a brief picture. I think it is quite saying lack of mechanical chewing, which will lead to absence of saliva. So proper brushing with the chlorhexidine antiseptic, and the cleaning of the oral mucosa or the oral cavity with the help of a nursing staff will be very, very helpful for the patient, so that eventually he or she might not develop any dental plaque formation or any gingivitis. So the recommended chlorhexidine solution strength is 0.12%. This is for the VAP bundle checklist we have. So oral care has been done or not, head up of the bend more than 30 degree, daily sedation vacation, that is from time to time. You don't have to sedate the patient for all 24 hours, so you have to break that chain. Daily assessment of readiness, whether breathing exercises were done or not, peptic ulcer disease prophylaxis, DVT prophylaxis, all these practices has to be followed, and which all are done every day. All the prerequisites of the patient has to be followed. So this bundle checklist for a patient is supposed to be done. Eventually, if patient develops ventilator associated event, so how do you trace it? How do you document it for your NABH practices? So these are basically the prerequisites. Post-procedure VAE, yes. What is the date of procedure when the patient was ventilated, this intubated? Who did it? What was the FiO2 values? Whether it is possible VAB, whether it is institutional VAB, we have to look forward for these. And what are the counts? What is the temperature schedule? What is the TLC count? What are the different antibiotics patient is being used? And the criterion, this, if at all you can see. So if it's endotracheal secretion or a bowel sample, what is the quantitative semi-quantitative analysis of the samples which was sent to the microbiology lab. This is one of the charts what we follow in my hospital. What is the name of the patient, UHID, age, sex, admitted, with whom, doctor's name is important. What is the date of event patient had we are suspecting it to be a VAP. What is the commonest organism? How many days patient was, more than 48 hours or beyond 48, before 48 hours only patient had symptoms. So how do we improve VAP? Hand washing. It is one of the utmost importance, single most important method for reducing any transmission in healthcare associated infections. And if not hand washing, hand rub with 5 movements of hand rub being followed in day-to-day practices. Moving on, next we have the central line associated or the catheter related bloodstream infections. Okay, very quickly, if I can say that, what is CRBSI and what are central line associated bloodstream infections? So to note it, first and foremost, CRBSI is important for us for the diagnostic criteria. It is not a surveillance parameter. So when we talk about CRBSI clinically or for the diagnostic reasons. But for the surveillance purposes, what we talk in our routine activities, it is central line associated bloodstream infection, that is CLEBC, used mainly for the surveillance purpose only. So what is central line associated bloodstream infections? How do we do the surveillance? It is number of central line bloodstream infections divided by denominator is total number of central line days multiplied by 1000. Okay. What is the criteria for confirmed bloodstream infection? Patient has a recognized pathogen culture from one or there is one theory called as, yes, it has to be a paired blood culture. No single blood cultures are no more entertained. And 2 blood cultures, an organism culture from blood is not related to any infection at any other site. So it's only blood related only. Patient at least one of the following signs and symptoms, which includes fever or chills with rigor, increased TLC count, and one of the laboratory findings leading it to laboratory confirmed bloodstream infections. So what are the causes basically? As it was used in catheter associated UTI, we spoke about the catheter. Again, 3 categories are there. Patient related, patient can be immunocompromised, immunodeficient, severe underlying disease, or any debilitating patient, or with the loss of skin integrity. So such patients are at risk for developing this central line associated bloodstream infection. Then we have this device related, same like catheter composition, thrombogenicity, flexibility of the catheter, microbial adherence, type of catheter, how many lumens are there, and what is the site basically. It is very, very important to note that subclavian site is very much important, and with proper sterile practices and single lumen use catheter to be used, and the various types of catheters generally we use for in our setups are polyurethane or Teflon, and not more than 30 days it is supposed to be kept. And thirdly, we have this healthcare worker related, that is breaching the practices, breaching the effectivity of with poor hand hygiene or the poor personal skin. A trainee or an intern or a very fresher is just trying to put up a central line should not be appreciated, should not be encouraged for. They can be trained, and after training they can be putting up the central line for this, because you don't know whether the patient is immunocompromised. Even if not, a trained personnel should be doing it. What are the most Commonest agents, so in gram-positive, we have this Staphylococcus aureus, and for gram-negative, members of Enterobacteriaceae family, and uh, from Pseudomonas aeruginosa, from the Pseudomonaceae family also. These are the culprits leading to central line-associated bloodstream infections. There will be foreign body insertion, a brief pathogenesis, biofilm colonization, and leading to thrombophlebitis and patient leading to sepsis. As I said that there cannot be single blood culture vial or a single blood culture sample should be taken. It should be a paired blood culture which should be encouraged. No catheter tip culture should be done. And this should be for the urine samples also. Sometimes doctors, they try to send you that catheter tips, urinary catheter tips also, and you have to take it. I think you should strictly contraindicate, you should strictly stop this practice that catheter tips are not to be entertained in any of the practices, whether it's catheter associated UTI or central line associated bloodstream infections. Catheter tips should not be entertained. Okay. Very quickly, if I can talk about the positive result for the semi-quantitative methods, what we use. So this is the Bactec 9120 system. Many of the laboratories nowadays they have, and these are different blood culture bottles, automated blood culture bottles. So one word my clinician always asks me, like, what is the differential time to positivity? DTP bataiye madam, isme kya aaya hai? So what is DTP, differential time to positivity? First and the foremost, when are you collecting the sample? When it has arrived to your lab. So if it's within the setup or you're not sending it to a standalone lab, from one hospital to another, because some hospitals don't have the provision of laboratories. So they send it to labs outside. So what time it has arrived to the lab, when it has been entered into the Bactec system or your automated system, whichever you are using, when was the positive sign it was given. So time to positivity from the insertion of the bottle inside, from the time it has signaled, the yellow light it has come. So that time, differential positivity time has to be analyzed, and at times clinicians are very much interested to know about it. So from the collection time till the time you are reporting, not only the signal, after the signal you have cultured, you have subcultured it, and after that you're putting it on identification, whether it's a manual or automated method, that completely depends on lab to lab. What is the identification and what is the antibiogram we have got for a particular organism. So time of reporting is very important, and we should provide to give clinician report as soon as possible we can. Okay, so this is a checklist for central line associated bloodstream infection. Again, the name, one second. One second. I hope I'm. Are the slides moving? Oh God. Please excuse me. I think the net connectivity has gone. If I'm audible, I don't know whether I'm audible or not. One second. Please, one of you, please let me know if I'm audible. Yes, I'm audible. Fair enough. Right. Thank you. So where were we? Okay, we were here at central line bundle checklist. I hope I have made myself clear for this semi-quantitative culture method. So differential time to positivity, as I said, and these are different blood culture bottles. We have it for the pediatric, we have it for the aerobic. Sometimes when they ask for the anaerobic cultures also, we have this different bottle. So different bottles for the bactec system we have, and it is very much helpful in giving us the corrective identification and the antibiogram for the different organisms. So this is the central line bundle checklist, as I was talking about. So you are filling up the prerequisites, the names of the name of patient, diagnosis. I don't know what is wrong. Okay, so who inserted it and who has removed it? What is the type of CBC what we have used? Whether the hand hygiene practices was done or not? Barrier precautions were taken or not? Skin antisepsis, dressing was done properly or not? Who inserted this catheter? What was the site of catheter? It is very important. And the days from 1 to 30 or 31 days are supposed to be monitored every day, and we need to fill up this checklist. Okay, very briefly, this is the same part, procedural checklist. What are the safety precautions you have taken? What is the site, what we have taken up? Whether the hand hygiene practice was done or not, cap or mask was worn or not, procedure was done by a proper cleaning of the skin, preparation was done or not, draping of the area where the central line was supposed to be placed. It was a sterile field, whether the person who was performing this was adequately monitored with the PPE or not. So this is one of the practices, though it is from foreign, but I think looks fine, that the area to be draped, whether the person who is doing it is wearing a complete PPE or not. And the central line is placed, jugular central line. This is the bundle list. And we look for date, time of assessment, date when dressing was done last. Daily checklists we are supposed to look for. So quality assurance and continuing education, how the surveillance of central line associated bloodstream infections can be done. Quality assurance and continuing education, whether it is SCOTY, whether it is WAP, whether it is central line associated bloodstream infections, everything has to be educating your staff as much as possible to have better results, to have less of healthcare associated infections, right? Then whether a subclavian site is preferred, yes, subclavian site is very, it is used at the maximum times for the central line association. Hand hygiene was done or not, maximum burial precautions for CVC insertion was done or not. As I said, subclavian site is very usually taken. Femoral site is very highest at risk for contamination. Hand hygiene was done or not. Maximum sterile barrier precautions and skin preparation was done with proper precautions. Chlorhexidine containing cutaneous antiseptics were used, and transparent or semi-permeable polyurethane dressings around the central line insertion should be done. And many a times nowadays, securing the catheter with proper dressing or proper suturing is also done. As I stated about catheter associated UTIs, their part, when the catheter is inserted, dressings have to be done, but for central line associated, nowadays suturings is also being preferred. So either of the practices what is being followed in your hospitals should be encouraged for. So educating and hand hygiene is the prior utmost prerequisites for our healthcare practices to improve in our setup. So unfortunately, still, if at all you have central line associated bloodstream infection, how do you fill up this form? This is one form which is followed in my area. So again, the patient ID, name, gender, what is the event type, that is CLEP-C, and what is the date of event, date of procedure when it was done, what were the risk factors for whether the patient was immunocompromised or not. It was a permanent central line, permanent as in more than 30 days, are you keeping it, or less than 30 days you are keeping it. Whatever the signs and symptoms, and laboratory recognized, as I said, laboratory confirmed BSI, LC BSI is important. So which pathogen, or the pathogen was one or single, or more than one microorganism was involved. If more than 2 microorganisms are absorbed, please go for a repeat culture, please go for a repeat sample, because it can be some of the laboratory contamination or contamination at the procedural activity would have taken place. Unnecessary reporting or excessive reporting is not required. So we have dealt about COTI, we have dealt about VAP, we have dealt about central line associated bloodstream infection. Quickly, if at all, I can say that what is catheter associated UTI. So number of catheter associated UTIs divided by the number days into 1000 is considered as catheter associated UTI. What is VAP? Ventilator associated pneumonias. What is institutional VAP and what is possible VAP? With the presence of organism, the total number of cases divided by total number of days per month in 2000 is taken as VAP. And lastly, what is central line associated bloodstream infection? Again, it is BSI, total number of cases. Denominator is again, as usual, the total number of days it has taken into 1000 is bloodstream infections. So catheter associated UTI, ventilator associated pneumonias, and central line associated bloodstream infections has been the three utmost important surveillance parameters for healthcare associated infections. Lastly, if at all, we can move on surgical site infections. But this is a very tedious thing. Abhi tak jo bhi kuch ho raha tha, 48 hours, 48 hours, 48 hours. So we were saying anything beyond catheter in situ, in urinary catheter in situ, more than 48 hours, yes, we can take up 40. Then ventilator, mechanical ventilation or endotracheal intubation is done for more than 48 hours is pneumonia. Any central line is there for more than 48 hours, we consider it with an organism and with the signs and symptoms to be bloodstream infection. But when we talk about surgical site infections, it is a bit of a different story. So what are the types of surgical site infections? We have the incisional or the organ space. And incisional is further divided into superficial incisional and deep incisional surgical site infections. So again, the benchmarks differ. The SSI rates range in India when we talk about, it ranges from 4 to 11 per 100 surgeries. So what is superficial incisional surgical site infections? So infections occurs within 30 days. Superficial and naam se pata lag raha hai. It is not 48 hours now anymore. It is within 30 days after the surgery and involves only the skin and the subcutaneous tissue, with at least one of the findings, which includes the discharge, which can be purulent, and the laboratory confirmation. The presence of organism, if there was a discharge, it was sent to microbiology lab for confirmation of any bacteria. So discharge होना चाहिए, एक organism आना चाहिए laboratory confirmation के लिए, and any infection which is occurring within 30 days of the surgery involving the skin and the subcutaneous tissue is called as superficial incisional surgical site infections. What are not to be supposed to be considered as surgical site infections? So any stitch abscess, minimal inflammation and discharge confined to points of suture penetration. Any episiotomy suture or newborn circumcision site is not considered as SSI, और कोई भी burn wound को हम लोग SSI में consider नहीं करेंगे. Many a time stitch abscess and episiotomy abscess, people they clear it wrong, saying that yes, it can be SSI. No, they are not. Before I further say about deep incisional, let me categorize the what are the different classes of wound. Wound class type. There are 4 classes according to the American Society of Anesthesiology, that is ASA score of patient physical status. Clean wound, that is the class 1, whereas it is an uninfected operative wound in which no inflammation is encountered, and the hollow viscous like abdomen or respiratory system or the urinary tract, it is not entered. So clean wound, the word itself defines uninfected operative wound in which there is no inflammation. Then in class 2 we have the clean contaminated wound. Operative wound hai, which can be of any respiratory or any alimentary or the urinary tract, but under controlled conditions ke andar with minimal or very unusual contamination is seen, is considered as clean or contaminated wound. Third one, the third category, the third class is contaminated wounds. So contaminated wounds can be anything open or a road traffic accident, or any fresh wound or any accidental wound is considered to be as a contaminated wound. Lastly, we have this class 4 as the dirty or the infected wound. Word itself defined dirty or the infected. So surgical procedures leading to any kind of peritonitis or Any abdominal exploration where active infection is involved and it is already present is called as dirty or the infective wound. So class 1, class 2, class 3, and class 4. Clean wound, clean contaminated wound, and the dirty or the infective wound are considered to be 4 classes for the surgical site infections. Then we have this deep incisional surgical site infections. Superficial one within 30 days के अंदर हो रहा है. Deep incisional is infection occurring within 30 to 90 days after the surgery, and it can involve any deep or the soft tissue or the fascia and the muscle layers. Of course, there has to be discharge. The culture has to be positive, and one of the signs and symptoms of pain and tenderness can be available. In superficial, also the criteria was same, but only the time duration was different. That was 30 days. So organ space, again, it is including the deeper parts of your muscles, and it can be opened or it can be redrained. There has to be culture positive, and one of the signs and symptoms, any drainage symptoms or any pain or tenderness has to be there. So we have 3 types, as I said: superficial within 30 days, and only involving the skin and the soft tissue. Deep incisional involves the deep soft tissues and occurring within 30 to 90 days after surgery with purulent discharge and with one of the organisms. And organ space, again, deeper parts of your body are involved with culture positivity. And one of the signs and symptoms of pain and tenderness are available. So what are the risk factors? It goes everywhere. Diabetes, all the reasons for immunocompromise. Diabetes, steroid use, malnourished, prolonged hospital stay, pre-op nasal colonization with Staph aureus. This is one of the having thing. No surgeon will want MRSA into their wards or in their surgery areas. So guide to hospital, it's a very funny picture from next we have uploaded it, MRSA ward. So once MRSA is spread somewhere, so it can turn out to be a complete MRSA ward, MRSA clinic, MRSA unit, department of MRSA or MRSAology. So staff should be well trained, and barrier practices, barrier nursing should be done. If one case of MRSA has evolved, so barrier nursing, strict following should be there. Other organisms involving SSI can be from gram positives, we can have enterococcus infections. And gram negatives, we have n number of bacteria evolving around from lactose fermenters to non-lactose fermenters, E. coli, Pseudomonas, Proteus, Enterobacter, Klebsiella, and many a times fungus like Candida albicans can be one of the culprits for leading to surgical site infections. Also, we have to see that when we talk about contaminated wounds, and sometimes when we talk about class 4 dirty or the infected wounds, many abdominal infections can be caused by this anaerobes, which are Bacteroides fragilis during bowel operations, during peritonitis. We are very, very prone to have this anaerobic surgical site infections. So this is one of the forms to fill up the surgical site infections checklist. Whether it is an MDRO infection surveillance, what is the event, when the primary incision was given, when the symptoms prevalent, when the purulent discharge has appeared, followed by that, whether it was a superficial surgical site, whether it is a deep surgical site, or it is organ space or surgical site infections. So again, signs, and what are the signs and symptoms? 1 second. What are the signs and symptoms? What is the organism involved? Organism identified from the blood specimen or from the any prosthetic or orthopedic surgery, if at all we can confirm about it. So clean swab should be sent, or clean pus sample should be sent, or purulent discharge sample should be sent to the microbiology lab to have a clear idea. If again more than 2 to 3 organisms are coming, please don't label it. For any superficial infection, if at all you are sending a swab and it is coming up to be a coagulase negative staphylococcus, please look into the history of the patient. If it's not somewhere from the cardiac area, from the CTVS area, any stenting is done, look for staph epidermidis, fine, understood. But any, what do you say that, clean contaminated wound, you're getting only coagulase negative staphylococcus, please rule out with the clinical history, then only you label it. This is a brief chart of how we fill up the form for surgical site infection. Again, the clean description about patient name, ID, when the patient was admitted, on under whom, what was the location of the patient, and what is the brief history of the patient, what are the pointers we look for. and what was the incision time. So what here only, if at all, you can add up one more point. What was the incision time? When was the prophylactic antibiotic given to the patient? Whether the surgery was somewhere in the morning and patient was given prophylactic antibiotic dose previous night only. Look for these points also. And what are the inputs from your surgeon? They are very much relevant for. So what are the standard of the universal precautions? I think I've been talking about it enough, and detailed personal precautions and isolated precautions ma'am will be taking up, Dr. Suchitra Jain. So in hand hygiene, use of personal protective equipment, safe injection practices, and environmental and medical equipment cleaning. This all in detail will be dealt with by ma'am. So very quickly, if at all, I can say about what are the 5 moments of hand hygiene. So before touching the patient, after contact with blood and body fluids, performing any aseptic task or any invasive procedure, and after touching the patient and after touching the surrounding of patient are the 5 moments of hand hygiene, which should be strictly followed to prevent and to have prophylaxis to reach what is happening and to lesser the burden of healthcare associated infection in your setup. So thank you, everyone.
Okay, so hospital infection control. The purpose of cleaning and disinfection is to ensure proper evidence-based practices for cleaning and disinfection of patients' care, equipments, and areas. Now, the responsibilities for this cleaning and disinfection, we usually say that, okay, the housekeeping staff or the general duty assistants, they should be working. But actually, the cleaning and disinfection protocols is the responsibility of all doctors, staff nurses as well. And we will see why it is important to have better cleaning and disinfection protocols. We have seen through various surveys, through papers, that if in cleaning and disinfection protocols, if our doctors and nurses are involved during the process, it is much better control, and the results or the effectiveness of cleaning or disinfections is very high. Now, in this topic of cleaning and disinfection, we will majorly cover patient care equipments. What are the equipments and which equipments need to be cleaned and disinfected, which equipments, along with the cleaning of the patient care area. So cleaning practices are what we have seen are often suboptimal, and we obtain few swabs. We can say that daily cleaning of surfaces near patients is often performed poorly. How you can check? You can take a swab from the cleaned area, especially beside the table you will come across, and in this picture you will see there is no difference between the cleaning before and after much, but and the other areas which we usually find are where the lot of microorganisms, especially which are passed on as hospital-acquired infection or VREs and MRSA, they are usually found on call button after cleaning. So there was one Carling et al. Finding that 47% of surfaces are targeted for terminal cleaning had been cleaned, only 40%. So what about the rest 53%? That is where the inadequacy is, that is what we have to correct. The contaminated surface, they contribute to transmission. We all know the contaminated environmental surfaces, they can contribute to the transmission of pathogens. This by serving as a source from which the healthcare workers contaminate their hands or gloves. Usually what happens, we have seen especially in COVID times that the patients, they were nursing staff were wearing gloves without hand washing or hand rub area, and then they would not change or do a hand hygiene. So that was the most contaminated surface, and this is the most important point of transmission of infection, our hands. So that is why all the stress, usually when we talk about hospital-acquired infection or whenever we talk about infection control measures, we usually give stress, and first and foremost thing is the hands. So hand hygiene is the most important part whenever we talk about. And contaminated medical equipments also, that comes into direct contact with the patient, they can also serve as source of transmission. So these are the two most important sources of transmission when we talk about hospital-acquired infection, and when we talk about hospital-acquired infections to lower down the hospital-acquired infections, we talk about infection control measures. So they are the two things which we will focus, especially when we talk about cleaning and disinfection. We need to clean these medical equipments, and we also need to clean our hands to stop more than 50 to 60% cases of transmission will stop if we take care of these two major chunk areas. Then the other contaminated surface which contribute to transmissions are patient admitted to a room formerly which was occupied with the VRE, that is vancomycin resistant enterococcus, or a MRSA, that is methicillin resistant staph aureus, or any MDR, that is multi-drug resistance pathogens. They are at increased risk of acquiring the organism, suggesting that the terminal cleaning of the room was inadequate. Terminal cleaning simply means that whenever a patient is admitted in a particular room, and if he had certain kind of infection, especially that is very those infections which can be transmitted easily from one person to another through hands or through equipments. So VRE, MRSA, and MDR, when we talk about, these are the microorganisms that easily get transferred. So if the patient had been infections and the cleaning of the room was not done, that is cleaning and disinfection of the room had not taken place, then this will contribute, this will continue to give the infection to the other patient who is coming into that room. So that is why the another infection control measures, when we look at cleaning and disinfection, we also talk about the terminal cleaning of rooms. And if it is inadequate, then patients can acquire the organism either directly from the contaminated surface or healthcare workers who have contaminated their hands in the room. So these will be the other two areas where the infection can pass, not just gloves, equipment, but also from the rooms if they are inadequately clean. So in these, you see, these are the danger points, and these are also called as the high touch points. We call it high touch surface area. So you see the monitors, these are the high touch surface area. We also see the bed rails, this is which is a high touch surface area. Then you see the monitors here, which are high touch surface areas. So these are the areas which, especially when we are talking about or making a protocol for cleaning and disinfection for any infection control measures, they should be taken care of. And there will be different kind of agents for cleaning monitors, or we say cleaning our equipments, and cleaning the hard surfaces, whereas there will be a different reagent when we'll be taking care of our flows. So there will be different cleaning and disinfectant reagents when we talk about different surfaces also. So hard surfaces, the monitors, the medical equipment, they need to have different disinfectants, which should be actually listed in an infection control manual, that what are the things which are used. So suppose in my hospital, I say sodium hypochlorite, which is a very common reagent. It is used for cleaning of the floors. Now for cleaning of the floors, we should know that what is the agent, what is the percentage of sodium hypochlorite required to clean the surface, and then it should go in the manual as well as in the training part, who terminally patients cleans the area. So that is what is required. Yes, I mean, you want to say something, you can interrupt me at any point of time. I'm okay with it. So somebody raised a hand, I think. I cannot see the message. So I'll go on. So there's a classification for medical devices, and this is called as Spalding classification, which is an international classification. And this says that critical items, semi-critical items, and non-critical items. So what are the critical items? Critical items are surgical instruments and implants, which needs to be, so it is 0.1%, 1% hypochlorite solution I'm talking about. Okay, critical items are surgical instruments and implants. Semi-critical items are which goes into the mucus. So critical items will be something which is going directly into the cavity. Okay, and semi-critical items will be which touches the mucous surfaces. So they are endoscopes, endotracheal tubes, and bronchoscopes, we can say. And non-critical items we define as stethoscope or thermometer, which usually do not have invasive things to go. So that is important when we talk about the clinical, the items which need to. And the most common sterilization and disinfections which we used in our areas is heat sterilization, ethylene oxide gas, that is called as ETO, which is usually used for plastics. Then there are glutaldehyde based formulations, wet pasteurization, we use it for 70 degrees centigrade for 30 minutes. For usually we use it for pasteurization of milk. And 70% isopropyl alcohol we usually use for the cleaning of the surface of skin surfaces. So any injection when we need to give, or any venipuncture we want to give, then we use 70% isopropyl alcohol. Then 1% sodium hypochlorite solution, usually for the hard surfaces we use for cleaning and disinfection purposes. Phenolic germicide detergents, they are usually used for hand hygiene. Phenols, we all know, alcohols. Then I forgot to tell, glutaldehyde based formulation, especially when we talk about OPA, Sidex, OPA, they are the agents which are used for endoscopes and bronchoscopes. Then iodophor germicide detergent, especially when we are talking about the surgeries, and iodophor iodine reagent is used. Quaternary ammonium germicide detergents, they are usually used when we are talking about the cleaning and disinfection of hard surfaces. So when we are cleaning our floors and all, instead of hypochlorite, we can also use quaternary ammonium germicide detergents. So any of the reagents, these are some of the most common sterilization and disinfection reagents when we use in our hospital setups or in clinical setups. So in front of each has its own properties, and each has its own way of working, the contact time, and they need to all defined in an infection control manual whenever we are talking about clinical and disinfection. So what instruments, suppose if I'm writing a protocol for ETO, I know that items which cannot be autoclaved should go in ETO, especially the plastic ones. So what is the cycle, what and should we have an indicator whenever we are having an ETO, is the ETO plant is in-source and outsource. So all these things need to define in infection control manual. I'm not going into the detail, but just for an example, this is I'm telling. Then for glutaldehyde based formulations, as I told you, that I'll give you a very interesting fact which we had it. So glutaldehyde is 2% glutaldehyde is the formulation which was used, which was coming by the name of Sidex, and we were using it for bronchoscopes and endoscopes. So once we found that there was an outbreak of actually Mycobacterium murium. Okay, so whichever the bronchoscope we were taking, and the washing whenever we were taking from there, we found that this organism was growing. That means the effectiveness of glutaldehyde was compromised. So we changed this glutaldehyde to orthoparaphenaldehyde, and from there on we stopped having any of the outbreaks of infection. So whenever you are defining that, the protocol should be defined in a manner that whether it's first, what are the steps. So in cleaning up steps of equipment, when we talk about bronchoscope, first it should be washed with clean water, then with an enzyme, an enzyme must be used to remove the protein particles. Then we dip in orthoparaphenaldehyde for 20 minutes, and this can be used for 14 days, the protocol says, but you should have each day a strip should be used to see whether the indicator is working or not, and then we have to dry it before actually we can use it for another patient. So all these steps should be defined for each disinfectant, and what equipment are using, in what kind of setup area they need to be defined. So this is just a observation. I'm giving you an example. The items which enter vascular system or blood flow through them, this is called as critical items. As I told you, the items except dental will come into contact with mucous membrane or non-intact skin. This is high level disinfection. And for sterilization purpose, like critical items, we usually use heat sterilization, that is autoclave, or we use an ETA. And the examples for this are surgical instruments. We all know that all surgical instruments should undergo autoclaving, and there's a protocol attached to how the autoclave works. So autoclave should have a particular cycle, say at a particular temperature. So 121 degrees centigrade for about 20 minutes at 50 Pascal, 15 Pascal unit for 15 minutes. That is the optimum time used for our autoclaving. But whenever we are using an autoclave, we should also have a biological indicator which needs to be checked with every item whenever we are using that. So the high level disinfection, the items which except dental will come contact, these are high level disinfections where we can use. And the Sidex and OPA is the one which you use for, and the instruments are endoscopes, endotracheal tubes, bronchoscopes, and other similar items which goes into there. So for intermediate level of disinfection, we say that some semi-critical items or non-critical items can be used, such as the isopropyl alcohol and so for example thermometer, they can be used, and they need to be, now usually the hospitals indent each thermometer for each one. We are in COVID time, especially there's a use of invasive, especially when we talk about in mouth, we don't insert, especially we use it only in the armpit area, so we can clean it through isopropyl alcohol. Then low level disinfections, non-critical items which come in contact with skin only. So we can use an isopropyl alcohol or a disinfectant which can be approved by Hospital Infection Control Committee. And usually the things which come into is stethoscopes and bedpans which are coming. For non-critical patient care equipment, especially when we are talking about disinfection method, disinfect non-critical medical items with accepted disinfectant using concentration and contact time, which usually are recommended by manufacturers, and usually the contact time is 1 minute, often effective. But when we talk about patient care devices which are visibly soiled, then we should wash it and on a regular basis after use of each patient or once daily. If dedicated equipments are not available, then disinfect items after using on a patient which is being isolated due to resistant microorganism. So just to quote an example from my hospital, what we do is suppose a patient of MRSA is there and he is having upper respiratory and he's using a vaporizer, or so we dedicate one of the instruments to that, and it cannot be used on any other patient until and until patient is gets discharged and fully clean the equipment. Same way it goes for the ventilator also. So after each ventilator, according to the manufacturer's guideline, there are certain dedicated equipment that they can be used only on the patients of tuberculosis, proven tuberculosis cases, and every time the patient use, we autoclave the cassettes of ventilator before actually putting into another patient. So this is how we disinfect or autoclave or sterilize our ventilator cassettes whenever we have to use on a resistant microorganisms. Otherwise, if the patients are on a non-resistant or an MDRO, we are using HME filters on both the sides so that it can be used continuously. So this is how we define according to the use or according to the patient or according to the microorganism that patient is harboring. We define our policy, and according to that only we have the cleaning and disinfection protocol. So non-critical environmental services, for non-critical, they prepare disinfectant solution as needed and replace them with fresh solution frequently. So we all know if we are using sodium hypochlorite solution, then the efficacy of that is only 4 hours. So each shift, if you are using once, then every shift will have, if it is a shift of 8 hours and you have to clean it twice, then you have to at least make the solution again, or in each shift you have to train your staff, your housekeeping staff, that a fresh solution of sodium hypochlorite is made, and then only it needs to be thrown off and a new need to be made. Same way, if you have to Floor mopping, usually solution is in our hospital setup, we change it after 3 patients room. So we say because the load, or we call it as a soiled load, will increase once it cleans one. So after we observe that after 3 patients room, the efficacy of sodium hypochlorite is not good. So we have trained our staff in such a manner that they change the solution every 3 patients room. And or if they have not cleaned, so it should be changed if 60-minute intervals also. So this is how we have defined our protocol for non-critical environmental services. We also decontaminate our mop heads and cleaning cloths regularly. So usually what we ask them, they dip it in sodium hypochlorization, though the fibers get destroyed, and the hospital staff, the administration is usually after life that usually the mop heads are being due to it's a corrosive material, but we have insisted that okay, in solution of 0.5% hypochlorite, we will dip it and dry it in a sun, and then only those mop heads can be used. Then detergent and water, they are also adequate for cleaning surfaces in non-patient area, especially if we are talking about administrative offices. So we usually don't use hypochlorite solutions for cleaning administrative offices. A simple soap and water solution is used to clean those surfaces. If we talk about critical care area, surfaces should be cleaned with 1% hypochlorite. And when we talk about electronic equipment that I showed, like monitors and all, they are cleaned with basilol spray. Basilol spray has hypothenol chloride solution, which does not harm the equipments. Usually the electronic items, they cannot be cleaned with sodium hypochlorite solution. So that is why this basilol spray is used. Mopping should be done with 1% hypochlorite every 2 hours. So in my ICU, the instruction is that every 2 hours they will wipe it with 1% hypochlorite. What happens, the more you use the cleaning and disinfection protocols, the bacterial loads remains low and it doesn't build up. So we have asked a special duty staff is there in critical areas that every 2 hours he will be cleaning each bed. Okay, and the OR as well as cath lab area are also cleaned with 1% hypochlorite in between cases, and we usually allow around 20 to 30 minutes usually before the second case can be taken. And OT tables, they are disinfected with Tuffy. Tuffy is nothing but a ready-made disinfectant available along with again with sodium hypochlorite solution. So all OT tables will be cleaned once the patient is taken out of the OT room. The floor will be clean and the OT table will be clean, along with the changing of everything, which we all know how to do it. Then cath lab area is also usually cleaned and with beacon with 1% hypochlorite solution, along with each day also. In non-critical areas, surfaces can be cleaned with 1% hypochlorite, and the mopping is also can be done, but it can, like I said, in non-critical areas, we have done only with soap and water. Then there's another interesting feature which has come in COVID was that whenever a patient was in a COVID rooms, the another patient was very critical of using that room. So ideally they were dedicated rooms for COVID, but when we try to convert the COVID room into just a patient area, the demand to disinfect that room came. So fumigation is not allowed or fogging is not allowed. So we had asked for an automated mobile UV light units that emit UVC, that is 254 nanometer range, that can be placed in patient's room after patient discharge and terminal cleaning had been performed. So this was a mobile light which was used for disinfecting any room with the patient of COVID. And believe me, the vegetative bacteria and all viruses, if you go through UVC light that is 254 nanometer range, it kills all vegetative bacteria and also kills spores, and it significantly reduced any bacterial count in patient's room. It was easy to use because once you take it, you on the plug and you leave it for 20 minutes, and this is all what was required. And no, the only thing required is that you should have a dark room. You usually put up the curtains, and you also close the areas, if any ceiling. So nobody should be there in the room whenever you are having a disinfection by UV lights, because it's harmful. And but it was easy to use. So we had procured 2 or 3 lights whenever we were wanting to have a disinfection of the rooms also. The most important part, which I would say in improving clinical and disinfection practices, is educate housekeepers regarding recommended clinical practices and the importance of hospital cleaning policy. Now, this cannot be stressed enough, because they are the pillars who will be actually cleaning and doing the actual disinfection process. So that needs to be taken care of. And the infection control nurses of the hospitals, they are usually appointed to train the housekeeping staff. So there's always they can be a trainer program. You can train the housekeeping supervisors, and every monthly meeting you can have a housekeeping done, especially if we are thinking of trying to change any already used solution for many years. Then we need to train them more vigorously so that nothing goes wrong and nothing goes up. And we should also ensure compliances of housekeeping staff with cleaning and disinfection procedures. So how we do it in our hospital is that we ask the nursing staff of that area to sign it on the register in which they have cleaned. So that keeps a check on the housekeeping staff. They develop that whether the area is clean, whether the equipments are cleaned properly, the surfaces are clean, and whatever the protocols are they are being effective by these methods. So training of housekeeping for cleaning and disinfection protocols, that is a must procedure. So this was all about cleaning and disinfections. What is that about? So do's and don'ts of glove use. I think the speeds get slowed, and that is why sometimes it doesn't stop. Work from clean to dirty, limit opportunities for touch contamination. That is what required. Protect yourself and others and the environment. Don't touch your face or adjust PP with contaminated glove. That is what we want. And don't touch environmental surfaces at necessary only to the patient care. So the mask, the other important identity which we talk about is your mask, and it is to protect nose and mouth. But in this era, we have seen different uses of masks. Some are below chin, some are like below the nose. So that is not we should be using. So all type of masks we have seen, and I'm not going into the detail. There was N95 cloth mask, the masks which were of double layer, triple layer. So many kind of masks were used during the COVID era. Coming to the sequence of this is the most important slide I would like, that whenever we have to don our PPEs, don simply means that you have to wear your PPEs. What are the things? So according to the CDC guidelines, it says the first to go is gown. So whenever you are wearing something, and when we were talking about the COVID, the gown, it was like before gown, actually one pair of gloves was worn, and before subsequently to hand hygiene. So first we will do a hand hygiene, then we will wear gloves, and after gloves we have to wear a gown. So gown, somebody can help in the tying, or you can tie yourself. Then comes the mask on a respirator, which you should be taking care of, and then goggles and face shield, and then the second pair of gloves. And in between, you have to use a hand hygiene. All hand hygiene steps should be taken whenever we are prepping. So this is how. Select an appropriate type and size, then open it the back, secure it neck. If gown is too small, you can tie it in front and one in the back. Then place how to don a mask. Usually place it over nose, mouth, and chin. Fit flexible nose piece over the nose bridge. So there's always a clip which you have to clip it, secure and head with ties or elastic, and then adjust to fit. For donning eye and face protection, the position of goggles are over eyes. They need to be there behind the earpieces. But the most important part is that you should adjust to fit comfortably in this. And then gloves, usually the gloves are the last, because that will be the most contaminated part. And if you touch any surface, then everything gets contaminated. So gloves needs to be last to want. Select correct type and size. So you should know before actually you, sometimes what I have seen is nursing planes beautifully 2 or 3 pairs of gloves in front of surgeons so that they can fit into the size if the surgeon is new. Otherwise, the nursing staff is too smart. They know which surgeon will wear which kind of a glove. So this is something which I really appreciate from their part whenever we see OT operating. Extend gloves over isolation gown cuff. That is the most important thing. So this gown should not, glove should come over the gown elastic band. Then how to remove personal protective equipments, another very important point which we should know, that the contamination causes more harm than the donning part. So contaminated and clean areas of PPs is contaminated outside front. So usually areas of PPCs that are likely into contact with body sites, material or environmental surfaces, the infections organisms may reside. So the first part, the part which is exposed outside, is the most contaminated one. And since the clean part will be inside or outside bag, ties or hands and back, so areas that is not likely to be contact with the infectious organism. So the sequence of removing is actually opposite. What we usually remove is the first pair of gloves. So there's a way how to take out the gloves. So outside of the gloves, they are contaminated. You take out the one, keep it in the other hand, and then take out the gloves from the pinching from the lower side, and then take the gloves in that particular gloves pocket usually. So people, those who are professionals, or we say pro in taking out, they usually take out the gloves in this manner only. And once you take out the gloves, you should clean your hands with alcohol gel. Then the gown, it should be like, because we know the back will be non-contaminated and the front will be contaminated. So you reverse the gown whenever you are taking off from your body. Then comes the eye protection from the outside without touching any other areas. You take out the outside protection. And then comes the respirator, because that is where the contamination you will take up, or you will breathe every contamination on that area, particular areas. So you should take out the respirators last. So that is how you remove gown, or we call it as a doffing purpose. So see, this is how the grasp outside near edge, peel away, turn gloves, and then hold it in the opposite glove. So this is how they are doing. Unglove and then discard. This is how the removing of gown. Unfasten, peel away, turn contaminated outside, fold and roll into a bundle, and then discard. Then you remove gloves, press from the ear or headpiece, never from the front, lift away from face, place in designated respectable. Sometimes they were used for reprocessing when they were not available. Then also removing the mask, untie from the bottom, then top, and remove from face and discard. So this is the most important part when we talk about doffing of personal protective equipments. We perform hand hygiene immediately after removing PPE. So if hands become visibly contaminated during PPE removal, wash hands before continuing. So ideally, whenever you are donning, you should wash hands, and whenever you are doffing, that means removing PPEs, you should always wash hands. You should not restrict yourself just using a hand rub. This is what I have to say. In cross, wash hands with soap and water, or use an alcoholic hand rub, whatever. This is again order of, if you have to wear a shoe cover, then first shoe cover and then others come. So commonest cause being improper segregation, recapping of needles, transportation, reuse of needles, and banding. So these are the most common causes of needle stick injury when we talk about. So if you're exposed to needle stick injury, what do? The most important point, that you simply need not to panic. That is the first thing I would say, that we need not to panic. And in case of exposure or injury immediately, we should have a first aid, and that should be treated to everybody in the hospital or your clinic or wherever you're working. Wash off with soap and water. You encourage bleeding, but never squeeze. So let the blood flow if there is any injury. So, you know, there are coagulation factors which will stop the bleeding if it is PT-INR is okay. And exposed mucous membrane, including the conjunctiva, if it is splash, then you have to wash copiously with water and try to find the source of it. Then reporting is, you should always report to your supervisors or whoever is available, so that they can take a note and extent, because you're panicking, but somebody else can note. how the injuries happen, and they can find out even the source where this needle and stick injury happens. Then you also test H for HIV, HPV, all 3 H markers you need to test sometimes if the source is a patient or and self also what is your status. And if positive, you have to take treatment as prophylaxis per orders. If negative, then you also need to inform. So there should always be a form for needle stick injury. In our hospital, we have kept in the emergency because that becomes an emergency. So emergency officers sign it. So you have to give the history, how the injury happened. Then you have to give the details of source. So if you know that this patient you were taking care of, and this is a patient where the needle stick injuries has happened. Then you give history of hepatitis B vaccination, immunization. So you give your history of immunization. Usually now it is a protocol in all hospitals that vaccination is mandatory. So that it should always be done. Then give your blood for testing of anti-HPS antigen, HPS, HCV and HIV. Anti-HPS just to know the titers, that is what is required. Then follow the treatment. Usually a physician is appointed to follow up if anything, any untoward incidents or has not happened with our healthcare workers. Then complete the needle stick injury form. Incident form is then submit to ER or infection control nurse. The investigations which we usually do for follow-up case is follow-up time period of investigation is according to the international guidelines, and it says 0 days, 6 weeks, 12 weeks, and 24 weeks. That is what is required. Then and all nursing should be vaccinated, not just nursing. Everybody should be in the hospital setup should be vaccinated against hepatitis B, and record is usually maintained with our infectious control nurse. Vaccination schedule for hepatitis B is 3 doses, day 1, 2 in 1 month, 3 approximately 5 months, and give intramuscular. So 015 is the month how we go about it. Then this is the immunization schedule of my hospital. That for doctors, hepatitis B, influenza, and these are the important one, and along with the COVID now we can say. Nursing, they need to require hepatitis, influenza, chickenpox, no typhoid, no meningol. For microbiology staff, we use hepatitis B, influenza. So I, being a microbiologist, I have taken hepatitis, influenza, also taken typhoid, also taken meningococcal. Then paramedical, my hospital, my laboratory staff, they are immunized with hepatitis B, influenza vaccine, and this is mandatory along with COVID. Then housekeeping, the most important part is hepatitis and influenza, we give it. And now these days, the new protocol says that tetanus should be included for their vaccination. Then F&B staff, usually a typhoid vaccine is must for them. We don't give hepatitis, but we are thinking of giving now hepatitis. Then outsourced staff, you may have housekeeping and other people, and usually a typhoid vaccine if it's a kitchen staff. So in my household staff, usually the F&Bs are there, so that is given only hepatitis, typhoid vaccine. The disease schedule is given, hepatitis needs to be done, and then the titers are done usually. Influenza is given annually, then chickenpox given 2 days, second dose after 4 to 8 weeks of the first dose. Typhoid is given 1 dose every 3 years. And then meningococcal is given 1 dose every year. So this is, you can design your own vaccination schedule just to prevent needle stick injury. The only important part is that you should have hepatitis vaccination done for sure. So post exposure, if the patient is said to be hepatitis B positive, from which the injury has taken. So for hepatitis, the healthcare, if he is vaccinated, then if we have to take out the antibody titers. So antibody titers, if it is more than 10 international unit, we don't give it. But in our protocol, we have, this is the international unit, we have included 20 international units. If healthcare workers is not vaccinated, then usually we give immediate vaccination within 7 days. But the first thing we give is hepatitis immunoglobulins, which is 0.06 milliliter per kg, and intramuscular need to be given. If the antibody titer was less than 10, that patient might be hepatitis antigen negative. It could be antigen source, or patient is HIV positive. It could be any of the 3 scenarios in this case. So if it is unknown source, And if the antibody titer is less than 10 in our healthcare workers, we need to give booster dose or complete the series according to. If it is a positive, then definitely immunoglobulins needs to be done if the patient was, the healthcare worker was not vaccinated. So hepatitis, immunoglobulins along with the booster doses usually given. So in follow-up, in case of hepatitis B positive source, test exposed for hepatitis antigen and anti-HBs levels, decide on appropriate prophylaxis. Repeat these antigen at 3 and 6 months, and usually a gastro reference is done, because along with that, LFT, KFT, LFT especially, and liver amylase, SGOT, SGPT needs to be checked every 3rd and 6th months. We do it. If suppose a post-exposure prophylaxis, if the patient sources hepatitis C, then in that case, determine the state of source. Usually no active prophylaxis, we know immunoglobulins are not effective, and interferons are usually not recommended for prophylaxis. So what we do is we take a blood test for HCV, RNA, LFT, KFT, CBC, and then repeat LFT after 4 weeks, and usually take a gastro reference in case of if the source is hepatitis C positive. We also test the exposed for anti-HCV and baseline LFT. We also give internal medicine consultants, and anti-HCV and SGPT of exposed at 4 to 6 months is usually done. But when we talk about post-exposure prophylaxis of HIV, it is very confusing. It is very difficult to actually lay down the protocols if it is an HIV positive. But believe me, if the source is HIV positive, please go ahead and see the extent according to the needle stick injury, and then decide on the post-exposure prophylaxis. It is an emergency medical response that can be used to protect individuals exposed to HIV, and it should be given as soon. So we give it within usually 24 hours. But sometimes the delay can happen. The patient does not, the healthcare workers doesn't come out. So it can be done. So common side effect with post-exposure prophylaxis, because it's include anemia, nausea, peripheral neuropathy, neutropenia, and myopathy. But the drug regime for the HIV are as per guidelines of NACO. So vidarabidine, that is efruxifermin, 600 milligram, with tracibutine, 300 milligram. And this is once a day. It's an oral, and we have to keep on doing it for 20 days. Dopamine along with ramiprazole, once a day before breakfast and 30 days. And then we say the Bicassules, it is given, that's a multivitamin oral for 30 days. So we have to keep on this schedule for 30 days for any HIV prophylaxis. If this is, if it is confirmed that exposure or extent is of HIV patient and the it is fitting up the criteria, this is the regime we are following in our hospital setup. But safe needles and safe life, this is what we should be teaching our staff, so that the untoward incidences are, and usually what we should be taking care is, we should be mapping our needle stick injury, which is the staff, say nursing staff is the one, or the housekeeping is the staff, which is the one, or the doctor. So interestingly, I will share an incident. We were having a lot of nurse GDA housekeeping staff, which were having a lot of needle stick injuries. But lately, so the RCA was in that case the improper segregation from the nursing staff rather than the housekeeping staff, which were at fault. So what we did was we trained our hospital nurses for proper biomedical waste segregation rule, and this has gone significantly. The needle stick injury of our housekeeping has gone down. It didn't affect the nursing staff, but definitely housekeeping was the one who was benefited by this training program. Now, these days, what we are seeing is the doctors are having high rise in the needle stick injury. When we found out what was the reason being that they said they are not trained for needle stick injury protocol. Now, this was very not very healthy to hear, but then we took up to the OT superintendent in our case, and we said that the surgeons, those who were operating, they are a little bit uncareful. So what they found was the nursing practitioner in one of the was new, and the way they were passing the instruments like retractor or taking the needle for perfusion and all, that was not correct. So this is how we had reduced the particular sort of needle stick injury, in particular OT also. So whenever a needle stick injury happens, please go through the RCAs, that is root cause analysis, to lower down your needle stick injuries, because it is not just one needle. If you take out the cost of one needle stick injuries which we have taken, it comes around 50,000 rupees for a particular follow-ups. And if any, apart from any mental trauma, which the healthcare will also be going. So just be careful. Every needle stick injury needs to be taken very carefully. And that is what we say. I didn't understand that question. Maybe you can excuse me why. So coming to the spill management, this is again an important part of infection control, that how you manage your spills. So spill management policies, in case any kind of spill will be there, blood and body fluids spillage can be there, chemical spill can be there, biomedical waste management spill can be there, or cytotoxic spill. So I tell you, all these 2, 3, 4, these are the major spills, we call it. And we divide only blood and body fluid spillage as minor and major spills. So minor spills, we call it less than 30 cc. What you have to do is wear gown, cap, mask, gloves, gum boots. Place a lot of tissues or newspaper over spill. Call the spill management team to clean the area. So in our hospital, we have trained every supervisor at a floor to get the minor spill collected. So every floor and every has a spill kit, which has certain contents, like the hypochlorite solution might be there or might not be there. It all depends. But there will be a trash can, there will be yellow bag, there will be hand gloves and PPEs, and usually an incident form inside the spilled kit only. So we have a bread box kind of a thing where these things are kept. And whenever the spill or minor spill happens, they help in cleaning. So what they do is they pour sodium first they take out the tissue paper, just so that the spill does not get outside the area. And then they put sodium hypochlorite solution and wipe it after 20 minutes. Same happens in major spill also, but there's a hazardous team which takes care of the major spills, especially of biomedical waste if happens, cytotoxic or a chemical spill. Now the contents of this is usually different from the minor spill kit, because it has got an absorbent paper, it has got an absorbent sand, it has got sand, also in which you can use for electrical and other things also. So that is a major hazmat kit we have created for major spills. And this can also be used for cleaning up 30 cc or any urine or body fluids also. So they call it a number. We have a dedicated number. You can also dedicate a number of a supervisor or something, where in our case it is 8224. They announce that spill has happened. This is the area. They will call their name. That is, I am Dr. Suchitra Jain. The spill, there is a major spill on 3rd floor in this area. Please get the kit to get it clean. So usually a team of housekeeping along with the supervisor come, they bring the spill kit, they will make the sodium hypochlorite solution, they will cover the area with big newspapers so that the spill does not go on, then make this freshly prepared sodium hypochlorite, they wait for 20 minutes and then they dispose of in yellow bag. This is what the protocol for major spill is there. So in some outbreak, this may be immediately obvious, but infection occurring in patients discharged after a short hospital stay may unrecognized sometimes. Many outbreaks, they are first detected in microbiology laboratory, and due to increased isolation or unusual pathogens, the laboratory must respond to the suspicions of ICD as soon as possible. That is what it is done. So initial investigations, their outbreak exists. It makes an initial assessment to determine the nature and size of the outbreak, if confined to the hospital, and whether there's community implications for it or not, if outbreak is likely of any major importance or not. So major outbreak control group is usually formed, which will meet according to the need of accused phase of outbreak. So functions, what is important? So the functions really considered about the patients, staff and visitors, and they should ensure that adequate communication. So in this era of mobile, I think the communication is well maintained. And we should also have clarified the resource implications for any outbreaks management. So the 3-4 important things we need to keep in mind whenever we are talking about infection, major outbreak: the staff, the patients, and the communication part. Then we should have people should coordinate the policy or the decision on the investigation and control of outbreak whenever we have any implementation issues. So to consider this, sometimes an outside help. So there can be a project management team also sometimes to help us out. And like in this COVID, we had ICMR, which came as an outside help. They made formulated policy, and that is what the policy was there for all the hospitals. You should also have clear instructions or information for ward staff. That is what is required. Also the daily review progress, which is very, very important. That is important, which we should be agreeing on what should be the written agenda, minutes and actions every time, because sometimes what we have seen in COVID also was some medical legal implications also come if they have not formulated the policy, if we have not circulated any policy, and the information to ward staff and patient is not demonstrated in a documentary form. So what I'm talking about right now is about outbreak management, or how to document each and every set process to move forward in case of outbreak management. We should also define the outbreak and evaluate lesson learned. So whatever the new findings keep coming, we should document it and keep on evolving. That is the main purpose of any outbreak management committee or outbreak management coordination, which we call it. We should also have criminally report that who was the contact process, who is the any first case, who is the second case, and how it is the disease is progressing among the community or maybe in the hospitals. So we should also inform others inside an hospital staff for the lessons learned. Then head of the nursing staff, director nurse anesthesia, that is what, and director emergency. These are the main members who should be the of the control group. And usually director anesthesia, in our case, he is a medical director also. So we have put a chair of infection control committee for that. But additional members, that is what is required in case of outbreak control group, is that it should have a critical care team head, Department of Medicine, Director of Laboratory Services, Catering Manager, CSST, Housekeeping, Hospital Chief Pharmacist, Supplies. All this is important because anything which goes wrong, we will also require investigations to be done. We will also have food facility available, that like in COVID, no, attendants were not allowed. So the catering manager has to be there, how to provide soup without any contact. So there was a policy regarding that also. CST managers, how to disinfect our equipments which were used. So there were patients in the ICU setup also. There were patients who were going through cardiac procedures also, and even OT procedures. So he was very clear how to tackle the patients. So he had need to be a part of that additional member team. Housekeeping, definitely, what were the disinfectants required, how many people are required to clean that area. Chief of Hospital Pharmacist, he had a hard time in this COVID because during mucormycosis, there were no drugs available. So that he was a part of outbreak control. Suppliers, initially in initial phase, we remember not even N95 masks were not available. The gowns were not available. So any major outbreak control should also have supplies, or the resources should be available to the hospitals or clinics or whatever setup you have to manage any outbreak control. That is important. The responsibility of continuing care of infection patients lies with the consultant under. So there's the consultant whom the patient is admitted, he cannot go away with the responsibility. So ultimate responsibility of the consultant. Now all other members, all other team, they just help this person to have a better outbreak control. So that is what is required, we say, for the patient care. But what we need is active or passive immunization should be considered, antibiotic prophylaxis should be considered for patient care, protective isolation for susceptible individuals need to be considered, whether the patient need to be isolated in one room or a dormitory can be created, or a cohorting of the patients can be there. Then isolation policies needs to be implemented. Additional, if any possibility, like any other hospitals, if your hospital is full and you do not have a step-down ICU, say, then you may consider other hospitals for a step-down procedure also. So we had hired few hospitals around, so where not so serious patient could be admitted. Then policy on patient admission, transfer, how you transfer patient from one ward to another, or suppose you have to transfer a COVID patient to an X-ray unit, how you transfer, which is the lift, which is the dedicated lift. So that needs to define all in case of outbreak management control group within. Visiting arrangements, so there were no visitors allowed in COVID, expert advice to be implemented, and any additional servicing and medical staff. So all this comprises of the patient care, towards patient care, along with the responsibility of the consultant, that is need to be fixed in this case. Then for community, for good communication, individuals or organizations need to be informed about nature and progress of outbreak. And one member, not all members can speak on the behalf of major outbreak control group. Only one person can speak, whoever is an expert. So in this case, only the microbiologist was allowed to speak. So because it was an infectious disease outbreak and most of the cases were through the microbiology diagnosis, that was the only reason that we were made in charge for the outbreak group. So need any additional staff could be there. It could be clerical, domestic, laundry. Isolation facilities need to be defined. The ward needs to be considered. The procedures need to be defined, what we can do, what we cannot do. So effectiveness, planned admission need to be considered. So admission advisor was taken into loop. Now this we are talking about the management part. He might not be a part directly of management control group or outbreak control group, but these are the associated people, those who will be required. Supplies, staff protection and antibiotic prophylaxis, catering procedures, as I said, housekeeping procedures need to be defined, nursing, medical and paramedical staff need to be informed. And especially if I don't talk about the death of infected patient, that was the most serious matter when we have come across COVID. So in second wave, it was very, very difficult to keep any dead body, because by the government, we had to label any death. Maybe COVID, may not be COVID. We had to tell them whether this is a COVID or a non-COVID body. And the procedure for burial or for whatever the methods that were required for the infected patients, due respect must be given. And there was a procedure how to pack the body and hand over to the attendants. That was the most important thing when we had come across COVID deaths. Investigation. So who is responsible for investigation? The epidemiological. So a case definition need to be defined. In case of any outbreak like gastroenteritis, a food sample might need to be informed. Sometimes if MRSA outbreak, we involve engineers. Environmental samples are usually taken and they are given to reference laboratory. I'm not talking about COVID. This is generally general investigation I'm talking about here. Epidemiological studies, like if we talk about the outbreak which is happening right now, is monkeypox and foot and mouth diseases. So a case definition is defined. Who are the people, those who are come, epidemiological study in progress needs to be defined, and any follow-up contact patients needs to be defined, whether the patient, staff, visitors, family, and communicating. So along with that, definitely microbiological or screening of serological screening of apparently non-infected people need to be considered. It may be for patients, relatives, visitors, staff, or other contact as well. The control is most important when we talk about any outbreaks. So here I will be talking about more a general control, like suppose I have an outbreak of MRSA, that is methicillin resistant staph aureus. So in that case, no active or passive immunization will be required, but only antibiotic prophylaxis may be required sometimes, or screening for nasal swabs may be required. Protective isolation may need to be needed. And if we have enough isolation facility, we might need to isolate that person from which the MRSA might be spreading. Disinfection policies need to be defined, say which is the best reagent which will be used for controlling, and what are the things which are required. Any new admission surrounding that area should be done, and or if any discharges are required in that particular area, we can. or any transfer or other wards is needed. So this is very important when we consider any kind of major outbreak we are talking about. Then we also need to define about the movement of patients, how one patient is moved to another unit without infecting others. So the sole purpose of major outbreak control group, if we say, is to prevent people from having that same infection to the other person. So the whole idea is to prevent, to discourage any further infection of that particular kind of whatever the outbreak is happening. So for that, visiting arrangements also need to be taken, and special required for any infection to the staff also needs to be taken. So outbreak in management, what we done this, there was investigation from ICMR form was there, in which section A, patient details was taken, test initiation detail, personal details, specimen information for referring agency, any patient category, it needs to be corrected. Then the investigation according to the categories, under which the categories were finding. I'm not going into the details, as everybody knows by this heart which categorization was done. Section B also dealt with medical information. B1 in section dealt with clinical symptoms and signs, and B2 pre-existing medical conditions. Any hospitalization detail in B3 section, and B4 referring to any doctor details were given. We will also refer to biomedical waste management rule, because in COVID, everything was going into for incineration purpose. So they had to be labeled as COVID-19. So there was been, initially the policy said everything goes into yellow, but later on it was said that the segregation waste needs to be done. But then a dedicated COVID-19 facilities were created where all the COVID-19 waste was given. The rationale was developed for developing PPEs, like in COVID area screening. They all three things were needed, say COVID suit along with the N95, goggles and gloves. In non-COVID clinical areas, only three things needed. On non-clinical area, only 3-ply mask was needed. So according to the extent in which it has to be taken was taken care of. I'm not going into the detail of donning and doffing, as I've already explained. The COVID policy, it says that high risk is without a risk assessment was usually taken whenever the COVID positive patient was exposed to a staff member. So we had defined a risk assessment for our people for the management. High risk for those who were not wearing proper PPE and they had confirmed contact with COVID positive. So usually they were put into isolation and for and observe for at least 7 days, then only they could join the duty. In case of medium risk, we define if no aerosol was taken, but without PPE also. So they were usually seen for 3 to 4 days, and then they were taken back into duties. If there was no risk and only 3-ply mask was needed, so they were not isolated, they would continue the duty. If there was no risk and PPE were wearing, so there is no risk and they could continue working. So we have done a risk assessment also for all our staff in that case, so that they could be properly taken care of. And we had used 1% hypochlorite solution for 30 minutes in for cleaning and disinfection protocols. Then in case of dead body management, as I said, COVID sampling was done. All holes and bones were sealed. The wiping of body 1% hypochlorite solution, it was packed in body bag, and even the external surface of body bag was packed. So this is all about the outbreak management.